My name is Adam Gregg. I am proud to be the Region B representative on the PSW Board of Directors and your session moderator for this afternoon. I would love to share with you, in the spirit of storytelling, my story about my journey into PSW and to pharmacy in general. But I do not want to divert any time away from our two presenters, because part of my story is loving to talk. So, at any rate, this afternoon, our speakers will be providing a presentation entitled, "Has the Pendulum Stopped? The 2022 CDC Guideline for Prescribing Opioids for Pain." This session provides an overview of the updated 2022 Centers for Disease Control Guidelines. It aims to provide attendees with strategies to integrate the guidelines into clinical care delivery in their practices. Dr. Diane Johnson is a clinical pharmacy practitioner in pain management and residency program director in PGY2 pain management and palliative care pharmacy residency at the William S. Middleton Memorial VA Hospital right here in Madison, Wisconsin. Her practice locations include the Chronic Pain Management Clinic, the Anticoagulation Clinic, and the inpatient and outpatient pharmacies. She has an appointment through the University of Wisconsin School of Pharmacy as a clinical instructor and is preceptor to both PGY1 and PGY2 residents. Diane is an active member of the Opioid Safety Initiative Committee, CARA work group. I almost spelled that out loud. You're going to have to tell me what that is later. And Whole Health Committee, and co-chair for the National VA Clinical Pharmacy Practice Office Pain Management Subject Matter Expert Work Group. She is also an active PSW member, helping facilitate the PSW Pain Stewardship member meetup 4 times annually. Dr. Molly Shoyer is a pain clinical pharmacy practitioner and PGY1 pharmacy residency program coordinator at the Tomah VA Medical Center in Tomah, Wisconsin. Since 2018, she has expanded the clinical services provided to including prescribing controlled substances under her own DEA license. Molly is also a lecturer at the Medical College of Wisconsin School of Pharmacy in acute and chronic pain therapeutics, and is a clinical preceptor and oversees a pain management rotation for pharmacy students and PGY1 pharmacy residents. Molly is the Tomah VA Opioid Safety Initiative Committee co-chair and an active member of the facility's pain committee and suicide postvention team. Molly is also trained and credentialed to provide battlefield acupuncture and provides this service to veterans through the Tomah VA Whole Health Program. Don't forget that PSW has partnered with members to develop on-demand educational content available for continuing education credit on the PSW app. If you are interested in more content on pain management, check out the on-demand session, "Taking the Pain Out of Managing Acute Pain in the Opioid Experienced Patient." With that, please help me welcome Molly and Diane.
Thank you, everybody. We have no financial disclosures, unfortunately. The learning objectives for today, I'll let you read them here. In the interest of time, we weren't anticipating such a long introduction, so we're just going to dive right into the content. We all remember the 2016 CDC guidelines for chronic pain. I've got a quote here. I'm just going to read to set the tone for our discussion today. As part of the U.S. government's urgent response to the epidemic of overdose deaths, the CDC today is issuing new recommendations for the prescribing opioid medications for chronic pain, excluding cancer, palliative care, and end-of-life care. The CDC guideline for prescribing opioids for chronic pain, United States 2016, will help primary care providers ensure the safest and most effective treatment for their patients. What a great start. So let's talk about these guidelines a little bit more. As I just read, it's intended for primary care providers, not cancer pain, not palliative care, and not specialized pain management clinics. Also, if you read these guidelines, it doesn't talk about pain management. It talks about opioid use. So another thing to keep in mind when you're thinking about your whole patient in the use of opioid medications. What was good about the 2016 guidelines? It had an emphasis on monitoring urine drug screening and the prescription drug monitoring program. It recommended to avoid opioid and benzodiazepine combinations. Very good. It encouraged providers to move away from opioids as first line for treatment for pain. This was actually a pretty big shift because, as we saw in the 90s and early 2000s, everybody said to use opioids, use more opioids. They're safe, they're effective, they're great. Nobody should be in pain. And so this was actually pretty big news, this shift away. It briefly did mention function, which is good. It had a focus on lowering total daily dose, which we will argue if that's good or bad. And then as a result of this, at least 17 states had passed laws requiring or recommending co-prescribing of naloxone. So again, a great safety feature of people who were enacting the guidelines. We did see some consequences of these. As we remember, when these first came out, we were all pretty excited about it. And then we saw what was happening as these were applied or misapplied in various situations. We ended up seeing this whole list of things. And if you can read the reference here, this is actually directly taken from the 2022 guidelines, explaining what went wrong after the 2016 guidelines came out. So they did this part of the presentation for me. It was rigid application of the guidelines to all patient care settings, not just those ones who we mentioned earlier. It factored in cancer pain specialists, everybody. It led to untreated or undertreated pain. Again, we don't want to use opioids as first line, but now people weren't using opioids at all in certain circumstances. It led to serious withdrawal symptoms, inappropriate opioid tapers, and opioid discontinuation. Not directly with this, but as a result, you can see the downstream effect. We saw increased suicides. We saw increased street use of opioids as a result of these inappropriate tapers. We saw worsening pain outcomes and a lot of psychological distress in our patients. There was, like I said, this overdose with the shift from prescribed opioids to seeking alternative sources for their opioid medications, and the suicide with ideation and behavior. Do you guys remember the shortages we had of opioids right around this time as well? And so where was this coming from? Certainly could be a result of we're not supposed to use opioids and changes of manufacturing as a result. There was a lot of damage to patient-provider relationships. Patients were discharged from clinic. Patients were abandoned. They had nowhere to go. They didn't have any pain treatment. And then the providers had this fear of disciplinary action. I don't know if you guys had providers reach out to you saying, I got a PDMP alert that I'm a high prescriber. And is that bad? What's going to happen to me? Are they going to take my license away? And so providers really had that fear of not knowing what to do. I sat in meetings where providers like, well, I have to follow the CDC guidelines. Like, says who? But this was honestly what their thought was. And if they didn't, there was going to be a repercussion to it. As a result of the 2016 guidelines, 38 states placed limits on opioids. Insurance changes set in place based on these recommendations. And then patients, providers were stigmatized or maybe penalized in certain circumstances for continuing to use opioids in their patients. And so what this slide is getting at is how many patients need to be tapered to prevent one death from opioid overdose. Essentially what this is saying is that you need to taper a lot of people to prevent one overdose. So is that necessary? Can we just not taper that many people? And, sort of really thinking about the big picture and reframing all of this. So I want you guys to think about this. In your practice, what has the opioid crisis done to your compassion? You have a patient that is maybe coming to your pharmacy window, you're discharging them from the hospital, they present to your emergency room requesting opioids. What is your first thought? Is it that, oh, this person is in pain and I really need to help them? Or, ooh, are they drug seeking? Or, ooh, what's going to happen? I need to check their PDMP and get a urine drug screen before I can treat them. So have you seen these patients that get denied treatment? Maybe they were on their opioids for a long period of time and now the provider's not comfortable prescribing anymore with nothing else that changed with the patient. So did the pendulum overswing in that we're avoiding opioids at all costs, regardless of the patient and the type of pain? So 3 years later, the CDC came out and said, wait a minute, you guys are misreading this. And so they wrote down, unfortunately, some policies and practices were derived from the guidelines, which were inconsistent with it. So why did it take them so long to say this? We saw these right away. Everybody was talking about it. And then it's too little too late. These policies were already enacted. These providers already had ingrained in them that they needed to make these process changes. So it was very strange that they put this out. It's like, great, this needed to be said, but like 2.5 years ago. So now we get to the update from last year, which was, we were all pretty excited about. They told us it was coming for several years. And we were, we read the draft and could find out what they were going to say this time and where the pendulum was going to go and what we were going to do. I'm not going to read this to you, but since the first half of the presentation is based off of this statement. So one of the first sections of the 2022 guidelines was saying, you all took this out of context. Let's take a step back and look at the patient and how we can manage the pain without abandoning our patients and without maybe necessarily limiting access to opioids.
All right, so now I get to take over and tell you a little bit about where they went with the 2022 guidelines. And to Diane's point, we're going to review the first kind of section, which they spend a pretty significant amount of time acknowledging this past harm. So the CDC funded the AHRQ to conduct 5 different systematic reviews of new information out since 2016 when that guideline was published. Similar to the old 2016 guideline, they looked at opioid treatments for chronic pain, but they also looked at 4 new sections as well. And those included non-invasive, non-pharmacologic treatments, non-opioid treatments, treatments for acute pain from migraine, and just acute pain by itself in general. After looking at all this information and seeing what was out there, they decided we probably should update the guidelines. So thus the 2022 guidelines. After they looked at this, kind of did the research and looked at the evidence out there, they worked or did an engagement with the community, so both patients and providers, to look at values and preferences to really understand those kind of lived experiences that Diane was just kind of mentioning to us, right? All the stuff that we were seeing on the front lines and what that looked like. So they posted 2 federal registrar notices, and you can see the dates up there, earlier and later in 2020. The first one was kind of inviting that input from both prescribers and those using opioids to kind of tell us about kind of what that looked like. And then the second one was to look at some more individual conversations about those sort of things. So they're gathering all this evidence and trying to get information from actual real people and stakeholders. From that, they developed some emergent themes, and you can see those listed there. The biggest things, which kind of echo exactly what we were seeing, were, of course, unfortunately, we want to maybe steer away from opioids, but now there's lack of, these people that were recommending non-opioid treatments for maybe non-pharmacologic or non-opioid, their insurance isn't covering that, right? And so, or they don't have access to it. As I work in a rural health setting in Tomah, Wisconsin, and the number of patients that need to drive more than 30 or an hour to see us is a lot, and they don't have just anybody in their community to help them with some of these things. Of course, there was that big theme about the misapplication of the previous guidelines, the stigma that was mentioned already. Interestingly, nearly 15% of all comments that were received were about some mention of suicide or suicide-related behavior, so that's pretty significant. And of course, everyone, patients and providers, were saying, yeah, we really shifted away from that shared decision-making. And that's what we're taught as healthcare professionals, right? And we try to aim to do in clinical practice is, use these guidelines as kind of maybe our stop gates or maybe some assistance, but that doesn't mean it's the law, right? And that we should have this, patient provider interaction together. So as a whole, the new guidelines really have this softening of tone and the refocusing on individualized care. You're going to probably, you will hear me say a few different times, and I kind of feel like I'm reiterating it, but this is what the guidelines truly do, is reiterate that this new guideline is a clinical tool to help improve that communication between the providers and the patients, and to really help empower that person-centered care. They want to improve the communication, like I said, improve patient function, pain, and quality of life, all good things. That's what we would hope, and still try to reduce those risks of opioids in the treatment of pain. So again, these new guidelines are intended for primary care clinicians, but additionally, they expanded these new 2022 guidelines to be other clinicians as well. So applicable in the emergency room or urgent care, post-op, as well as even dentists can apply this. And it's for outpatients, so not inpatients, but outpatients over 18 years of age and older for any type of pain, acute, subacute, or chronic. And again, these are meant to be flexible standards, right? So not meant to be held as a law. The guideline is not, so they go through a specific kind of information about what this guideline should not be used for. Again, it's not a replacement for clinical judgment, right? It's not to be applied as inflexible standards, as we already said. And specifically, they call out and say that these guidelines shouldn't be used by healthcare professionals or health systems or pharmacies or third-party payers or government jurisdictions to lead to rapid tapering or abrupt discontinuation of opioid patients. And that's, of course, significantly what we saw, unfortunately, from the 2016 guidelines. Additionally, the guideline is not a law or policy or regulation, right? So it really doesn't dictate clinical practice or is a substitute for what the FDA says is approved labeling. Again, it's not applied to, similar to the previous guidelines, it's not applied to cancer-related pain or palliative end-of-life pain or sickle cell pain from sickle cell disease. It's also not to be focused on opioids prescribed for opioid use disorder, although they do mention that a little bit, and we'll talk about that in one of the recommendations. And it's also not to be, of course, used for adolescents because it's for 18 and older, right? So as already kind of put out in their initial statement, as Diane was reading or showing you all, they talk about, of course, that the laws and regulations and policies that were developed were not consistent with the central tenets of the guideline. So please, let's not do that, right? I feel like I'm kind of beating the dead horse, but honestly, this is what they do in the introductory of this guideline. As already was shown to you, there's obviously some things that happen from misapplication, and that's on the bottom there of the screen for you. Things like patient abandonment, dismissal, rapid tapers, like we mentioned. And because of that, of course, there was all these problems that happened, undertreated and undertreated pain, right? Serious withdrawal, suicide-related behavior or intent. So they want to move forward from those things. You'll see in one of the recommendations that they discourage the misapplication of actual like specific dosage thresholds. Previously it was don't go above 90, right? Or don't go above 50, all these different cutoffs. And what does that mean? Here, they don't actually give an actual cutoff, and we'll cover that. And what that kind of looks like. There's also revisement of the language that encourages, of course, health systems and payers to increase the access and affordability to non-pharmacologic and non-opioid therapies, which is great. I mean, if that's what we want to support and say should be kind of first line and incorporated in any pain treatment, we got to make sure that we have health equity and patients can afford those things, right? So just to kind of put it all together, the 2022 guidelines are voluntary. They're not a law. They're not supposed to be taken as kind of the end all, of course. And they really are meant to be focused on that whole person approach, which considers lots of factors. Of course, the patient's physical, psychological functionings, maybe their support needs, who they have with them and what their life looks like, and expected maybe health outcomes from certain treatments too. They also want to make sure that we're focusing on well-being, the patient's home environment and their home and work responsibilities. So making sure that we're giving patients good quality of life, right? And a buzzword in the VA is whole health, right? Thinking about not just, one part of your life when we're thinking about a pain, but the whole part of your life. And how does pain affect all of these things? And that's what the guideline is trying to emphasize, which is appreciated. So before we go into the 12 specific recommendations, it's important to look at kind of how, of course, they graded the recommendations. And this probably looks familiar because this is in accordance with the ACIP and the grade methods, grade recommendation, right? They consider clinical evidence, contextual evidence, and expert opinion when they looked at the creating the recommendations. So you're going to see, I'll list each recommendation and what its what its strength is. So there's going to be category A recommendations that are going to be applicable for everybody, and category B recommendations that are supposed to be kind of more individually evaluated or individual decision-making created. And then along with that, if it's an A or a B, then they'll give it an evidence type. So type 1 is going to be your strong evidence, right? It has randomized controlled trials or overwhelming observational studies. Whereas type 4, it might be a little more on the weaker side, where there's, more so just using clinical experience or randomized controlled trials with more major limitations included. So we covered most of this already. They highlight that there's 5 guiding principles when you're going to implement these guidelines. Number 1 is making sure that we are appropriately assessing pain, any type of pain, acute, subacute, or chronic, and that pain should be appropriately assessed whether or not opioids are going to be part of the picture. That's number 1. We need to make sure that we are actually effectively assessing pain. Secondly, making sure the recommendations are voluntary. Enough said there. Multimodal and multidisciplinary therapy or approach to pain should be implemented, right? So thinking about all those things I just mentioned, physical health, behavioral health, your supports, and so on. Avoiding misapplying the guidelines, as already stated, and then attending to those health inequities, like we mentioned as well. So ensuring that there's actually appropriate, affordable, diversified care. And that's what they state is kind of the big overarching principles. So we're going to go through and kind of look at each recommendation and just kind of talk a little bit about them. They're split into 4 different categories or 4 different sections. This first section is on determining whether or not you're even going to start an opioid for a patient, right? They, before this section, have a little statement, as I listed up here, that says all patients with pain should receive treatment that provides the greatest benefits relative to the risks, right? So just keeping that in mind, we still want to make sure we're not, first do no harm to our patients, right? But we also need to make sure that we are giving patients quality of life and helping them with their function and all the things that we already talked about. So the first recommendation is thinking about acute pain. The recommendation talks about using non-opioid therapies as they can be as effective as opioids in a lot of acute pain types. But we can't also forget that opioids are really important in acute pain, especially in some of these trauma or surgery types of settings. And they really have a place in acute pain management, especially for places where other therapies maybe are contraindicated or we know aren't going to be helpful. So of course, non-opioids can be helpful, but also we want to make sure we are maximizing those non-pharm and non-opioid things and still considering opioids when we know that the benefits are likely to outweigh the risks, right? So this is a category B recommendation with the evidence type 3. It focuses on just making sure we're optimizing non-opioid and opioid care where appropriate. Recommendation number 2 focuses a little more on starting opioids in the subacute or chronic pain setting. Again, similar to acute pain, there's the similar theme there where we want to use non-opioid therapies, non-pharmacologic therapies, maximize those things first. Only considering an opioid, again, if the benefits are going to outweigh the risks. And if you are going to start an opioid, making sure you're talking about those risks with patients and working to establish, okay, if we're going to start this opioid, what's our goal with it? What's our functional goal, right? Is it to help you be able to continue to work or to care for your family or walk around the block or whatever that looks like, right? There's a wide variety of that. And setting those standards with patients. And then also setting a standard of kind of an exit strategy at the beginning too, right? If we start this and we get it to a potentially reasonable dose and we're not seeing gains or we're seeing problems with it, we are going to probably not continue it, right? Same as we would do with any other medication for other disease states. If it's not helping you or it's causing harm to you, we can't reasonably continue it. They mention, of course, that opioids should not be considered first line, but that does not mean that patients should be required to sequentially fail certain things before they can be put on an opioid, which is great because that's unfortunately what we see a lot from the 2016 guidelines with a lot of SOPs or policies or things that were put in place that you have to fail every non-opioid and non-pharmacologic option first before you can even consider an opioid on the table. So it's nice to see that in the supplemental text, the guideline here does talk about, opioids may be required in certain settings even before you've failed all those other things. This is a category A, evidence type 2 recommendation. So the second section here is selecting opioids and determining the dose. So now you've decided you are going to put somebody on an opioid. What are you going to put them on, and what dose should we start them with? This section, or this recommendation, looks at if you're starting it for in an opioid naive person, you want to start an immediate release opioid. We all know in clinical practice, we're not going to start a long-acting opioid in someone who's never been on an opioid, at least not recently. We want to make sure they're going to develop that tolerance and not risk for overdose and all of those things, right? So makes total sense. This is a category A, evidence type 4 recommendation. Recommendation 4 looks at now, if you're going to initiate opioids in an opioid naive patient, you want to start at the lowest effective dose. And increase from there if we need to. If you're going to continue an opioid in somebody who's already on it, you want to use caution if you're going to increase, right? And evaluate those benefits and risks when you're going to do any dosage change. Here I italicized the bottom bullet, and this is where previously they probably would have had dosage thresholds, right? Don't increase above this certain amount. Now they just say avoid increasing the opioid dose above levels likely to yield diminishing returns and benefits. So basically, we can use our clinical judgment, right? If somebody is going to maybe benefit from going up to 100 morphine equivalents a day, it's okay. We don't need to say we shouldn't do that, right? The folks who put the guideline together did express that if they put specific dosage thresholds again, as they already saw happen before, we're going to have that emphasis on those and causing them as absolutes and saying that we absolutely cannot do this, right? And that's not, of course, what they're hoping to do. But they did put some kind of comments in the supplemental text of maybe some ideas and benchmarks, because we know that maybe there are some things that we should think about. If you're starting an opioid naive person, you probably don't want to start them on 90 morphine equivalents right away, right? And so they made some comments about maybe some reasonable doses to start people on, or to consider with changes in dosage. This is a category A, evidence type 3 recommendation. So category A meaning kind of applies with everybody, right? Recommendation 5, this is thinking about, well, you have somebody on opioids, when are you going to reassess them and determine if it's still appropriate? So making sure that you're evaluating the risks and the benefits if patients are already on them, especially when you're thinking about making a change. If those benefits continue to outweigh the risks, great, continue them. That's fine. And you might even be able to increase it if you need to. If the benefits don't outweigh the risks, and now the risks are starting to kind of pop up as more problematic, you probably want to optimize other therapies first, and maybe continue to reevaluate and think about whether tapering or reducing to a lower dose could be appropriate for this person. They do talk about, trying to make sure that this is individualized, right? And this isn't you're on it today and you're off it next week type of thing, right? And reevaluating that over time as you continue to go. I bolded the bottom point here in that it says, unless there's indications of life-threatening issues or warning signs of overdose, we should not be abruptly just tapering or stopping an opioid, right? And unfortunately, this is what we saw a lot. I got into a number of professional disagreements with providers about why it's not appropriate to just send somebody a letter that says this is your last fill and here's what you're going to now no longer take, right? Or just start to taper them without even having that conversation with the patient. Obviously, I probably am preaching to the choir about why that's problematic, but thankfully they try to maybe right their wrongs here and specifically call out that that's just not appropriate. They do say in the supplemental text that clinicians and patients might not be able to agree on whether opioid tapering is necessary. And if that's the case, clinicians should acknowledge the discordance and express empathy and seek to implement changes in a patient-centered manner while avoiding patient abandonment. So again, I mean, we are healthcare professionals, right? So we need to make sure first we're doing no harm. So I guess we can't necessarily say, for my license, I don't want to taper, or I don't think you should continue this, but maybe it is, right? If it's not really in the patient's best interest and we feel those risks outweigh the benefits, even if the patient doesn't always see it, we need to work with them on that. And maybe we need to kind of help them, push them to see why that is the case. But we shouldn't just forcefully taper them without any discussion or any collaboration there, right? They also specifically call out that if you are tapering someone, you make sure you're following up regularly. And they actually state monthly, at least monthly. Interestingly, they also say that team members, for example, nurses, pharmacists, and behavioral health professionals could be helpful on this part of the whole deal, which is great. They called out a pharmacist in this guideline, which I was excited to see. They also state in the supplemental text, not in the main part of the recommendation, as you can see here, because this is what the main part says, but they also state that for patients who are unable to taper, especially those who are on very high doses of opioids, and maybe they don't qualify or meet the actual criteria for opioid use disorder, you might want to consider switching them to buprenorphine. That's a whole topic in and of itself, but obviously it's an emerging, kind of new hot topic in the pain world, and it's a good thing. I think all of us could have a good discussion on that at some point, but that was helpful to see as well. So this is a category B type 4 recommendation. The third section here is thinking about, if you're going to continue an opioid, again, how long should you continue it, and when should you do that follow-up? So here's for acute pain patients. They talk about if you want to prescribe no greater quantity needed than for what they're going to need, right? So don't be prescribing them extra just in case, is what they provide in the supplemental text. They actually suggest that patients should be evaluated at least every 2 weeks after starting an acute opioid. Interestingly, that's not cited from an actual study, but I mean, I think that is what we would hope to see happen. Interestingly, though, too, they also recognize that there's some reasons why that might not be as ideal, especially, patients who have those health inequities, right? Or transportation issues, or even just healthcare in general is busy, and can a provider see a patient in 2 weeks and then another 2 weeks, then another 2 weeks, right? But maybe this is where some of us could step up to the game, right? And have in some settings. So this is a category A evidence type 4 recommendation. This recommendation number 7 talks about if you're going to have follow up with somebody who is on for chronic pain, opioids for chronic pain. So you want to evaluate them 1 to 4 weeks after you initially start an opioid, and knowing you're going to continue it for just chronic pain past the acute stage, right? This, again, there's limited evidence to say, what should that time frame be, but we do know that, there's studies out there that show that, obviously opioid use disorder risk increases the longer somebody's on an opioid, and the overdose risk, especially after starting a long-acting opioid, is the highest in the first couple of weeks after they start the opioid. So the guidelines specifically call those things out and say that, we should be sure we're following up with patients and reassessing, is it helpful, is it not, are you having side effects, and do we continue? Again, they call out those same sort of things I mentioned previously, that sometimes there's going to be some barriers to that, and they recognize that. But again, this is a category A evidence type 4 recommendation. So the last section number 4, looks at risk and risk mitigation. And if you're going to be putting or keeping people on an opioid, how can we keep them safer, right? So recommendation number 8, in a nutshell, just says we should be offering naloxone to patients and assessing and evaluating their risk. Interestingly, they go into some information about why they chose the word offer naloxone instead of require naloxone. As Diane said, there had been some policies or some kind of laws put in place that if you're going to be prescribed an opioid, you must also be prescribed a naloxone prescription together, which seems great. But unfortunately, some people couldn't afford that, right? Or requiring that as a hard stop can be problematic. And so they recognize that here and said that even offering it or discussing it with patients is obviously risk mitigation, and suggesting to them, where can you get a naloxone prescription if you want to? Now, obviously, even since the guidelines have come out, we're super excited that the opportunity is that patients can go to their Walgreens and get it over the counter if they want to in the near future, right? Now that it's going to be over the counter. We're fortunate within the VA that patients have never had to pay a copay for naloxone. So cost has never been a barrier for us, but obviously that's not a reality in other places. So we recognize that. So this is a recommendation A, evidence type 4 recommendation. Recommendation number 9 looked at being sure that we're checking the PDMP for patients. So when you're prescribing an initial opioid for any type of pain, and it states, and periodically during therapy, we should be checking the PDMP. Now, again, we know that there's some state laws that require maybe some changes to that, or more strict or less strict rules per the law. Again, they talk about, as we saw from the 2016 guidelines, if you find something on the PDMP that maybe seems inconsistent, we shouldn't just be dismissing them or abandoning them from that and saying, I'm sorry, I'm no longer prescribing you, and cut you off. Again, they talk about that that's obviously a risk to patient safety and could represent that patient abandonment, and results in those missed opportunities to allow us to provide them life-saving information about what they can do about if they're using multiple prescribers or multiple CNS depressants, or what that might look like. So they want us to be sure we're discussing the information with the patient, we're discussing safety concerns. The other thing that they recognize too is that PDMPs are obviously run differently in different states, and in some states by county. So the reliability of being able to see things can be problematic too. So again, with some of these risk mitigation things, maybe the PDMP being one example, you kind of have to take that for what, a grain of salt, right? Or not just use that as a hard and fast rule. We need to have that as a part of the whole clinical picture when we're talking to the patient. This is a Category B evidence type 4 recommendation. Recommendation number 10, this one is talking about looking at toxicology screening, so whether that be serum or urine drug screen. And they do recommend being sure that we are considering the benefits and the risks of testing for this. Obviously, they can be helpful. They can check for both the prescribed and the non-prescribed controlled substances that you are trying to intend the patient be using or not using. But again, they specifically state that we shouldn't be abandoning people based on a urine drug screen that might not be as expected. Interestingly too, as we hopefully all know and think about often, at least I do, is that urine toxicology tests don't obviously provide accurate information of what dose and how much they actually took, right? It just says it's there or it's not there. And so does that really give us a lot of evidence to say you've been using this all the time, right? Or I'm going to just completely say it's not appropriate. Again, we need to take that into the clinical picture and discuss it with the patient. And also they mentioned specifically in the supplemental information that there was some concerns about, of course, the accuracy and clinician interpretation of urine drug screens, the cost, and the delay in care, to say, I can't fill your opioid until your urine drug screen comes back. And we know that sometimes, especially if you need a confirmation, that takes more than just an hour. And so now you're going to say somebody had been on 90 morphine equivalents of something, and I can't fill it to you until next week. Now we're causing withdrawal and all of these sort of negative things, again, that we were seeing from the 2016 guidelines. So things to consider when we're thinking about pros and cons here, but they do suggest that it should be considered. This is a Category B evidence type 4 recommendation. We're almost to the end of the recommendations. So number 11 is to think about the opioid and benzo combinations again, right? So using caution when you are prescribing opioid and benzos, consider whether the benefits outweigh the risks. And they also call out here too, in addition, other central nervous system depressants as well. Specifically in some of the supplemental information, they are sure to say that things like buprenorphine or methadone for opioid use disorder should not be withheld for people that are on benzodiazepines. Obviously, they're being used for a different opioid use disorder, right? They also interestingly call out and say that consider involving pharmacists as part of the management team when opioids are co-prescribed with other central nervous system depressants. So kind of cool, again, that we get called out, but we get called out for helping manage maybe these tough cases, but that's okay. That's what we do, right? And they also state, as kind of discussed earlier, that rather than saying that opioid and benzos together are a direct cause of overdose, they might maybe serve as a marker for risk for overdose. And that actually stopping benzodiazepines or even an opioid, as we were discussing before, can be destabilizing. And that could be more of a problem or a risk than just long-term long-term use, and making sure you're risk mitigating and discussing risk versus benefit, and maybe doing some very slow tapering a 0.5 milligram reduction in 2 years could be a great success, as opposed to just cutting somebody off and having this erratic, unpredictable use that would be more problematic and risk for overdose. The last recommendation here talks about opioid use disorder. And even though this isn't the focus of the guidelines, as we said earlier, again, they do say that you want to offer and arrange treatment for opioid use disorder if you really suspect that that is the case. And knowing that detoxification, so just abstaining, is not recommended because that increases risk. So typically patients might need medications to assist them. Again, they call out that we shouldn't be dismissing patients just because they could potentially have opioid use disorder. And they also mentioned here too that, again, people who maybe struggle with tapering or can't taper should be reassessed for opioid use disorder and might be a good candidate to switch over to buprenorphine. So again, this is a category A, evidence type 1 recommendation. So that's a pretty strong recommendation. All right, I'm gonna hand it back over to Diane and take a break.
Thanks, Molly. So that's great. I think if you read the guidelines, we all in the pain management world agree with this. It's like I could have written my practice and this is how I operate my practice. So really fantastic. So why am I going to spend the next few minutes talking with you about the concerns I have with these? So these are really well intended, but where's the evidence? So the recommendations A were just over half of them. And so that means like, yeah, we're pretty sure these should be applied to all in half the cases. And I didn't write down how many of them were evidence level 4, but if you were keeping track at home, it was a lot of them. And so if you remember, that's our lowest level of evidence, almost based on just expert opinion. And so the CDC spent all of this time, they said they spent this 6 years looking for evidence, doing the research, finding the best way to do things, yet they could only come up with level 4. So really, what were they doing? I don't know how many of you really like when you're reading a guideline like this that has, 300 references to go and check all of them. Yeah? No, I'm the only one. So they spent the background doing the statistical analysis and review, and of course the opioid epidemic. The statistics on drug overdose data was as recent as 2010. This is 2022 they wrote this. There has to have been more recently published data. The misuse statistics were from 2020, so getting closer. And then most of the data in the background, they could have just like copied and pasted from the 2016 guidelines because the evidence in their statistics were from prior to 2016. And so when you think about it, it's like, well, what are they basing all of this off of then? They talk about, all the overdose risk and suicide risk, but they didn't report any of that in their background because they don't get into the information. So again, like I said, when I'm reading it through, I'm thinking, okay, I agree with this, but I still don't have anything to support what I'm saying. It's just this expert opinion. This is Christopher M. Jones. He looks like a really nice guy. He is the only pharmacist author. So there's like 3 paragraphs of authors and consultants and other people who had input on this, the guideline development committee or whatever they were called. 1 pharmacist. He's not even a pain management expert. So again, while he'd be really fun to hang out with and talk shop, I just don't know that he was the right person to develop these guidelines. So, and I got this directly from like his profile. I'm not like making this up, but what he was doing. They also overstated the opioid harms. So if you read their statistics, they give the percentage of how many people overdose. So they cited this 2020 National Survey on Drug Health, and they say that 9.7 million adults age 12 and over. Think about that. How many of you have adults that are age 12? Misuse their prescription opioids. So who can guess? So just like a show of hands, 9.7 million adults aged 12 and over. What percentage of adults is this? 50%? 20%? 5%? 2%? Yeah, it's 3.4% of the population. So now had they said 3.4, would we have read this and be like, 3.4, that's nothing. But they say 9.7 million, and we're like, holy cow, that's a lot of people. And so I think they're trying to spin the way we're thinking about this information for our 12-year-old adults. Some other concerns I had There was no mention of actual like pharmacogenetics really within the guideline itself. I feel like this is really important. It's something that we've been considering for the last handful of years. So at least a mention would have been nice. So they talk about the equianalgesic dose conversions should count for variability in genetics. That was our keyword for genetics. That wasn't even in the guideline. That was in like one of the appendix where they had the equianalgesic table. And I did a search for the term patient specific, and it was mentioned 3 times in this whole, however many pages I scrolled on my screen, so I don't know how many pages there was. But it was with regards to the diagnosis and only once with regards to medications. Right? Shouldn't everything be patient specific? Like every single one of these recommendations, in my opinion, should have said something about patient specific medication plan. It still does, like Molly said, it didn't really focus on the MEDD, but it did mention not recommending to increase above the 15 milligrams morphine equivalent. So they didn't really focus on the numbers, but it's still in there. So it really does open that window for somebody coming in and saying, you're above 50, you're on high dose because you're above 50. And then I don't know if you've noticed, like if how many of you use the CDC equianalgesic table to calculate MME, they removed that. So it's no longer available online, but the equianalgesic table that they made references the 2016 study. So we're still getting the same information if you use their table, even though it was a little funky. Like, for example, they gave buprenorphine an MEDD, which anybody who prescribes buprenorphine or practices with it knows that's not accurate, and you really can't do that. Same with tramadol. It's a little weird, and like, should we really be giving that a number? But you know, if you got to be sure you're under that 50 milligrams, you got to give me the number. So it's a little bit tricky there. You know, and if you think about the supporting evidence that compares this 50, so why did they pick 50 instead of 90 like in the previous guidelines? There are few trials that actually evaluate greater than 90. And so I feel like even that 90 is still a little bit arbitrary. And what does greater than 90 mean? Like 400 or like 100? So there's that really big variability with what we're looking at there. So does this guideline do enough to reverse the stigma? What can we do? How can we look at these and apply them to our patients? More importantly, what has been done to improve the training and retention of providers who support our chronic pain patients? I didn't find anything that talked about like increased pharmacy school curriculum or medical school curriculum on how to manage chronic pain. So we've got these guidelines, and that's really what we're going off of. And like I said, I agree, it's how I work in my practice. But maybe instead of doing their hard work on finding all that new data between 2016 and 2022, let's funnel some support into the providers who are dealing with this day to day in our patients. So the last piece of the guidelines was non-pharmacological approach. So Molly, you want to talk about these?
So we thought it would be helpful to just kind of run through in brief. You know, we talked a lot about opioids, but obviously, as mentioned in a number of the recommendations, that non-pharmacologic treatment should be, you know, optimized or first line and used in all types of pain. And so we're going to just kind of run through a couple of things here. The guideline for acute pain, the kind of gray boxes is what the guideline specifically states are things that should be considered for acute pain. Again, as previously stated, you know, they recognize that unfortunately a lot of these things might not be always covered by insurance or fully accessible to patients. And so they do make some comments that, you know, there should be effort from health payers and, you know, healthcare settings to improve this accessibility and affordability and so on. So everything from heat to acupressure to massage to remote neuromodulation for things like migraine are all recommended for acute pain. They also cite that the ACP has some recommendations for, you know, acute back pain as well. When we look at subacute or chronic pain, these are the things that the guideline recommends or suggests as things to incorporate or consider for patients. And again, a little bit longer list, but you know, all things that we would want to offer and suggest to patients as well. They include things like CBT, cognitive behavioral therapy, acupuncture, physical therapy, Tai Chi, and so on. And again, they cite the same sort of concerns about accessibility and such. So that's what the new CDC guidelines say. If we look at other guidelines, so this is a snapshot from the low back pain guidelines from the VA. Again, they suggest that there's obviously opportunities for use of non-pharmacologic treatments. I won't go through these, but they're kind of there for your reference. So this is the second kind of continuation of that. Same thing is the case when we look at the treatment of arthritis. So from the College of Rheumatology and the Arthritis Foundation, they recommend that non-pharmacologic treatment should be there. Same does the EULAR guidelines from fibromyalgia. These are a little older, but that's the current guidelines for those. And then when we think about for neuropathy pain as well, again, non-pharmacologic treatment has a central tenet as well. As mentioned, we both are from the VA, and at least at my VA and all VAs, this is becoming and continuing to be really expanded. There's actually a list of non-pharmacologic offerings that need to be available at every VA healthcare setting, so or facility, I should say. So that's great because we're really working to increase the accessibility. And of course, affordability doesn't necessarily have to be so much of a barrier for some of our patients. Although, again, as I mentioned, I practice in a rural area, so sometimes the accessibility from that perspective could be more problematic. As Adam mentioned in our bios, I am credentialed to provide battlefield acupuncture. So I thought it might be helpful to just spend a minute or two to talk a little bit about that. This is something that, again, as a pharmacist, I at least can provide, and I think others, I'm hoping, could look into this as opportunities for expansion. Again, it's I'll tell you a little bit about it, and hopefully you'll kind of see where it could be a helpful offering to incorporate into patient care. So BFA or battlefield acupuncture is a form of auricular or ear acupuncture. There's lots of kinds of acupuncture, but auricular or ear acupuncture is an opportunity. BFA is a subset of that. It uses 5 specific points, and you can see the picture on the right there shows you what 5 specific points are used. It's the same protocol for every patient. So if somebody comes into me with a headache or diabetic neuropathy or low back pain or an acute ankle fracture, I use the same 5 points no matter what. It was actually originally developed in the military by a provider named Dr. Nim Tao, and he wanted to use acupuncture to treat pain, be quick and effective, and really be an additive therapy to hopefully not have to escalate medication doses and such. It's great because it's pretty easy to do. It can be learned by a wide variety of clinicians, including non-acupuncturist clinicians. And it's quick for the patients. We put 5 points in, they get left in, they remain in for 3 days, and the patients take them out themselves 3 days later. There's a lot of benefits. Obviously, it's helpful for pain, but as you can see, it affects a lot of other things as well. So patients also have some downstream effects even on mental health or other sort of diagnoses. And the great thing is that at least half of patients do report a 2-point decrease in pain immediately following having BFA completed. And that's great. The studies, unfortunately, that are out there for BFA haven't specifically looked at changes in function or quality of life, but I can tell you anecdotally from my patients, a majority of patients do have that benefit. And just like every medication, everything's not for everybody, right? So there's patients that get no benefit from BFA. There's patients that get no benefit from opioids, right? So again, having to reevaluate that for patients. And as I already stated too, BFA is very accessible. So at least within the VA, you'll find that BFA is integrated in a lot of different departments in different facilities that looks different. At least for us, we offer it in our whole health program. We have a whole floor, a whole clinic that's dedicated to whole health or these non-pharmacologic treatments and such. But we also have, it being provided in our primary care clinics. It can be provided in the emergency room. I provide it in my own personal pain clinic or pain med management clinic. And, clinicians that are outside of the VA or the DoD could potentially be trained in BFA if you could get it approved onto your scope of practice. So that ends our formal section, we do have the learning assessment questions, but you guys can look at those in the app. So I guess, I don't know where we're at for time. We can answer questions with the last few minutes. So
Yeah, so if you want to either go to the microphone or just raise your hand or come up and talk to Molly and I afterwards, that'd be great.
So I'll just kind of throw this out there. Obviously, repeated theme is patient specific, and we all get that. What would be your recommendations or just a general idea of getting these patients that are on just stupid high doses of opioids? And, I can think of one patient specific, I've been on this forever, blah, blah, blah. But you look in the chart, and it's like, there's no reason they ever should have been on this amount, and got them into a slow taper, very, very slow, been working with them every month and so forth. But you kind of want to end game. You can't pull the opioids entirely because you want to treat their pain. You want to be specific for them. And there is a justifiable reason for that. You mentioned buprenorphine. I'm just kind of throwing out whatever other ideas you got, because we've tried the other medications. They don't work, get those response backs. I think I'm going to take some of the stuff you got there and, put a list together for these patients, say, hey, let's consider these as well. But just any thoughts you got on that would be very useful.
yeah, I can start and you can add in. I guess then that's a great question. And that's something that we grapple with or talk with providers about and we think about in our own patients every single day. Unfortunately, I don't mean to say damage is done, but I mean, some of these people, like you said, have been on them for years, and to the point of continue to reevaluate, do they have opioid use disorder? And sometimes that's really hard to determine. There's some such things called CPOD, or complex, pain. Oh my gosh, persistent opioid dependence. Sorry. Yes. Complex persistent opioid dependence, CPOD. See, anyways, that is the kind of that gray area, right? Where do they have opioid use disorder? Or is it just because they've been on these medications for so long? And I think the important thing there is to just continue to reevaluate the risks and the benefits and determine if we can just keep providing risk mitigation opportunities. I'd much rather leave someone on 200 morphine equivalents when they're, everything seems appropriate and we are continuing to say we're keeping them as safe as we can, than just rapidly cut them off and now they destabilize. We still need to have those real conversations with patients, maybe engage motivational interviewing and, support them and encourage them that I'm right here with you. I can support you. And if we go down and it goes bad, we'll go back up, right? Or we will think about other options. And it doesn't mean that, we go down and that's it. So I think it's different from person to person. It's individually, we have to be individually specific. And now, hopefully continue to think about, is that a person that's appropriate for buprenorphine? If we do kind of continue to reduce and we can't go further, or they develop withdrawal symptoms or destabilization, that's a perfect person to consider buprenorphine. And I think it's hard to say an end game is that all of these people should just get off of opioids, because there is a subset of people that truly do function better on opioids. And I'm now seeing more often where I'm recommending people to be put back on smaller amounts. That doesn't mean we're going to put them back on 200 morphine equivalents, but their life has been a shambles since they've been off of opioids. And what's the harm of putting them back on 450 morphine equivalents, right? Especially if it's okay, and there's all these other things that don't seem problematic from it. Yeah. I don't know if you have other
Yeah, I'd
things.
just like to say, it sounds like you're doing the best you can, and sometimes that's all we can do.
So thank you for tackling such a difficult subject first and foremost. But so I work in a community pharmacy, and one of our biggest issues is dealing with early refills, for example. So I'm curious how you guys deal with or communicate to the people actually dispensing the opioid on early refills, and kind of what your guys' protocols are for that.
So I think, everybody has their specific protocols. I think a lot of it comes down to training the patient. A lot of our patients know the provider will not allow early refills. Sometimes there's, extenuating circumstances, but how many times can your aunt die and you have to leave town? It just happens to be the week before you're due. So it's really looking at those individual circumstances with your patient and what the provider is comfortable with. I think there's always room to talk about other risk assessments and assessing for addiction or other concerns that you have with your patients. I would also encourage all patients to have medications for withdrawal on hand. I feel like just the patient having those, even though they might not need them for whatever circumstance, can be really helpful, that help is there and they don't need to necessarily go to the emergency room if they are a couple of days late, or, most often our patients are just taking a little bit more than prescribed because they had a flare up. They went to the dentist and didn't get any extra, and for whatever reason didn't call their prescriber. So I feel like, most of the time there's probably a reason, but certainly with those repeat offenders, it would be talking to them about what's going on and having the provider maybe do an assessment for unmanaged pain versus addiction concerns.
Yeah, I guess I don't know if I have much else to add other than, at least at our facility, we have kind of a protocol in place for, what do we do with early refills? And I'm sure other places do as well. Yeah, I think, well stated. I don't have much else to say there.
Hey guys, I know we're pressed for time, so I'll give my question quick. So I know back with the 2016 guidelines, a lot of institutions moved toward looking at quality metrics in terms of monitoring opioid prescribing. And obviously we want to move away from a lot of those really stringent monitoring guidelines, but are there metrics that you guys at the VA have really looked at modifying and providing that feedback for providers on how we're doing with prescribing, or different goals that you guys have talked about strategizing out?
Well, and I think we both are looking at each other because unfortunately, we still, even though we just gave you a whole presentation that said we should move away from those things, it's still what we talk about every week. I have an 1.5-hour meeting every week that we look at the patients that are on opioid and benzos together and the greater than 90 people, and we review them on an annual basis. But I think that our tone in recommendations to providers, obviously has changed. It's not a lot of like, this person needs to get on the lower dose period. It's individualize that, discuss it with patients, that kind of thing. So unfortunately, we don't have other great metrics unless you can think.
Well, it's very high risk.
I mean, yes, true. We do have some other metrics in that we look at maybe patients that are very high risk for overdose or suicide related harms, and trying to, help them, improve risk mitigation, things like all the things we just mentioned. But, we still focus or think about those other things too, knowing that there's still potentially markers for unsafe, unsafe things happening, right? Or patient harm. So.
Yeah, I would just say the focus, we don't only review patients on high doses anymore. We do review like the high patients who have untreated sleep apnea. We review patients who maybe have had a suicide attempt or ideation and they're on opioids, and what can we do to kind of help support the whole person, not just necessarily looking at that. So we're lucky that we do have that dashboard that looks at the patient risks.
All right. Well, let's show our gratitude and appreciation for Dr. Shoyer and Dr. Johnson for a great presentation. The CE code for this afternoon session is on the screen. Thank you all for your time and attention, and I invite you all to stay for our final series of programming for both the EdCon and the residency conference at 4 p.m. Thank you.